Welcome everyone. My name is Brad Chickwin, and today we're going to cover documentation principles as it pertains to patient sign-offs and refusals. Objectives. Our goal is to cover the patient refusal QA/QI expectations and look at documentation examples on how to document properly. Some people believe that the QA/QI process is nothing more than Monday morning quarterback. You know what? I have to agree. It's exactly what it is. When PCRs are reviewed for completion and accuracy, we have to look at them in such a way that if you were a lay person on a jury, how would they take them? When we look at PCRs, all we can go by is what's written down. So, if it's not written down, it didn't happen. What we're trying to do with the QA/QI process is to make sure that you are covered legally should your PCR be subpoenaed to court. As it pertains to refusal documentation, it is one of the most common sources of EMS litigation. When fueled by personal injury, attorneys seeking to represent potential allegations of medical malpractice, claims against EMS providers have been rising for the last 3 decades. Refusals occur in approximately 5 to 20% of all EMS patient contacts, and in some systems may make up as much as 30% of the call volume. Competent adults, with a few exceptions, maintain the right to refuse treatment. The goal of refusal documentation is to limit liability. This is both to the provider and the service. Above all else, when it comes to documenting your care, most EMS personnel have heard the old medical adage of, quote, if it isn't written down, it wasn't done. And it's very much true. An EMT may take 5 sets of vital signs, but if only one of those sets makes its way into the PCR, it will appear at trial that only one set was taken. EMTs and paramedics should become familiar with the adage from the legal world, it's not what happened that matters, it's what you can prove. In court, medical documents carry a lot of weight. Forced to choose between a written document and a testimony of the witness, juries tend to believe what's written down. So please make sure your documentation is accurate and very thorough. Expectations here at the Raymond Fire Department. At least one set of vitals are to be completed on all patient refusal sign-offs. We need to make sure that we document the risks that were explained to the patient or the family for not accepting transport or treatment in both the narrative and the AMA section of the PCR. We'll cover that later. Also, it's really important to make sure to get an electronic signature from the patient acknowledging the risks. So let's take a closer look. Over the course of this program, you will see a variety of narratives that are going to be posted on the screen out front of you. For time's sake, please go ahead and pause when it comes time to reading these so that we don't take time reading them verbatim. So this is example number 1. This is the entire narrative. After reading this narrative, what do you think was wrong with the patient? With the way that it's written, it is very much contradictory, and it doesn't paint a very good picture what's wrong with the patient. Again, this was the entire narrative that the provider put in his or her PCR. Continuing on, looking at their PCR, when it comes to the patient refusal section, they selected that the patient refusal reason was against medical advice, yet nothing in the narrative you just read says anything about a life-threatening emergency or any indication that the provider gave them clear description of what the risks were, nor were they clear on it was against medical advice. In the narrative, the expectation is to make sure you include all of those risks that you explain to the patient in the narrative section. Also, in the AMA section, those same risks that you explained need to make it into this box. We have all had that conversation with the patient on if you feel the need after we leave at any point to please contact 911 or see your doctor if the problem worsens. If this was a case in example number 1, it was not clearly documented in the narrative. Also, the AMA initial disposition is patient refused transport, so this is in strict contradiction of the patient refused against medical advice. AMA interventions, they stated that the patient was attempted to go to the hospital. Again, there was no documentation of it. Continuing on with example number 1, the patient's alternative plan was to go home and monitor. Monitor for what? You need to be very clear in that narrative what you're advising them to go home and monitor. When it comes to the 7 questions as it pertains to competency, the provider did a good job expressing that the patient was oriented to place, person, time, and event. They were unimpaired by drugs and alcohol. They were competent to refuse care. They were advised to call 911. The risks of complications of the refusal have been discussed, and no medical care or only BLS care was rendered. They failed to select if the patient was 18 years of age or not. This does not have any weight on whether or not it was appropriate to sign the patient off, so please make sure you check the box whether they are or not over age of 18. Example number 2. Again, please pause this slide, take a moment to read this narrative. So compared to example number 1, it definitely has more information to it. The assessment is there. Good job at kind of explaining the scene, as well as the education at the end of the call. As compared to example number 1, example number 2 definitely has more detail in it, but sometimes the detail doesn't go deep enough. And what I'm pertaining to is the last paragraph. This provider wrote, "The patient is made aware that although she feels fine now, internal injury/illnesses cannot be ruled out in the field." What are those? If you're going to explain to them about internal injuries or illnesses that can't be ruled out in the field, you need to make sure you expand upon what those were in the discussion in your narrative. Also, this provider made the statement of, "The patient is made aware that the risks of the refusal accept all possible outcomes, up to and including death. If she signs a refusal, it releases the ambulance service of liability thereafter." I would never, ever, ever advocate to put this phrase in there. There are very particular instances to which you can use the phrase up to and including death. And somebody who is unable to sleep with a chief complaint of hypertension, most likely pertaining to the gummy that they took earlier in the day, does not fall within those parameters to utilize that phrase up to including death. On this slide are the examples to which, in most cases, it would be appropriate to utilize the phrase up to including death. And they pertain to STEMIs. So these are your ST elevation MIs that are identified in the field, verified by a 12 lead. You present the 12 lead to the patient. He or she absolutely refuses to go to the hospital, even though you would demonstrate to them that they're having a cardiac event currently. That would be a great example to use the phrase, if you don't go to the hospital, you will die from this. Another example, overdoses. We respond to our patients who's overdosed on some sort of narcotic. We wake them up with Narcan. They start to feel better. They refuse transport. We give them their Narcan kits. We educate them on it. Part of the education is we need to make sure we let them know that the Narcan that we just gave them to reverse their overdose may wear off and the potency of the medication that they've taken in there, it may still be in their system and may outlast that Narcan. Again, another good reason to utilize up to including death if they don't go to the hospital. MST, multi-system trauma. This is your motor vehicle crashes, so multiple rollovers, a host of injuries. They have all their faculties. For whatever reason, they refuse to go to the hospital. Again, another appropriate reason to use that phrase up to including death, because again, we don't have CT in the ambulances, we don't have MRI in the ambulances, we don't have x-rays in the ambulance, we can't verify that there isn't something internally wrong going on with them. TIAs. Remember, TIAs are mini strokes, so we very much can have a patient to which calls us for stroke-like symptoms. We assess them. By the time we get to there at the house, the stroke has now subsided or no longer shows any sort of deficiencies. The patient refuses to go to the hospital. This would be a great opportunity to utilize that line of up to including death, because they could have another stroke after we leave, which could then cause them to die. Allergic reactions. We all know best practice. Someone has an allergic reaction. We give them an EpiPen, or they give themselves their own EpiPen. We show up and the allergic reaction is getting better. If they have to deploy their EpiPen, they truly have saved their own life, or we have saved their life by giving the EpiPen. So it's important to advocate for them to go to the hospital, because, like with Narcan and opiate overdoses, given epinephrine IM, it could wear off depending on what the allergen is that's causing the allergic reaction. We could leave, the allergic reaction could rebound, they could become short of breath and or die if they no longer have another EpiPen. Another good example, head bleeds. We know anybody who is on an anticoagulant, medications like Eliquis, who fall and strike their head, have a significant risk of an internal head bleed. We can't rule head bleeds out in the field. Again, no CT, no MRI. So if these patients refuse to go to the hospital when they're on an anticoagulant, this would be another excellent example to utilize that phrase when you explain the risks of them staying home and not seeking definitive care, is that you could possibly die due to a secondary bleed that isn't going on at this time. Again, these are the examples to which I feel it's appropriate to utilize that phrase up to including death, but it is not a catch-all phrase that should be on every single call. So here's example number 3. So it tends to be a little bit more detailed and a little bit better than example number 2. So again, like the other 2 examples, please take a moment, pause this presentation, read this narrative. It happens to also be a 2-page narrative, so I'm going to click to the next slide as well so you can read the remainder of the narrative. So here's the rest of example number 3. As you can see, the first part of the narrative was excellent. The second part, which has the meat and potatoes for the patient refusal documentation, is also good. This provider did a great job of really honing in and pulling out the steps as it pertains to the patient being able to sign off. So he or she broke it down in an A, B, C, D, E, F, G format, where the provider clearly outlined the patient was calm, cooperative, and competent, greater than 18 years of age. Patient was offered treatment and transport to the hospital of their choice. They were offered transport to the hospital for any sort of diseases or injuries, diagnosed or undiagnosed, that they currently have. They were educated that they may have injuries that are not obvious at this time. They also went into the fact that they wanted them to follow up with their PCP, and that the services that they refused could, in theory, lead up to death. And then the patient was instructed to call EMS for any reason at all. They did a really good job saying the patient was educated that she could be suffering from AFib, stroke, a myocardial infarction, so a heart attack, or any other injuries or medical emergencies that can't be diagnosed in the field. The patient signed the electronic signing section stating that she understood the risks associated with refusal of transport against medical advice, up to including death, because again, educated on AFib, stroke, or MIs are all things that could lead up to death. Patient continues to refuse the transport, so it shows to me that this provider tried multiple times to convince the patient to go. Patient did say she would contact her PCP in the morning, and then again the patient was directed to call 911 at any time for any reason. Excellent example. Great job by this provider. So as you can see, the shorter the documentation has been, the less detail that's been involved, the more liability the provider incurred. Example number 4, very good narrative. It's an SOPA or SOAP sort of format. Again, pause it, take a moment, read the entire narrative section of this. You'll find it to be very detailed and very thorough, and they did a really good job of explaining the risks associated with it. So what I did from that PCR is pulled out the S portion of it and highlighted the highlights of the PCR that did a good job of explaining the risks. So the patient still refused transport, was informed that she could be having a cardiac event that the monitor did not detect because the 12 lead only captures an active STEMI, parentheses, current heart attack, which shows me that this provider explained to the patient what a STEMI was. But blood work taken at the hospital could also detect a heart attack. As we know, 50% of MIs are N-STEMIs, so there are no ST elevation in their EKG rhythm. So it's detected by troponin levels at the hospital. She was told that because of her high blood pressure that she could have a stroke. It needs to go to the ER to get it lowered and call her PCP ASAP. The patient still did not want to go to the ER. Patient informed that if her headache gets worse or if she starts to have any stroke-like symptoms, to include slurred speech, dizziness, sudden weakness, increase in headache, she passes out, or something doesn't feel right, to immediately call 911, and she agreed. Patient signed the electronic refusal paperwork and understood that she could call 911 at any point after EMS cleared the scene. Excellent example of not only listing out what the risks were, but went into detail with things like any stroke-like symptoms and made it very clear to the patient what she needs to look for. Moving on to the AMA section, provided a good job. After their full assessment, the reason for the refusal was a patient indicated ambulance transport was not necessary. On the AMA type, after assessment and treatment, I refused transportation to the medical facility for evaluation and follow-up care. What did the patient refuse? She refused transport to definitive care to be evaluated by ED staff for a possible cardiac, neurological, or GI issue. Dispositions, contact 911 and see the doctor if the problem persists. Inform the patient to contact her PCP. The AMA initial disposition, the patient refused transport, but she accepted an exam and refused the treatment. And then AMA interventions, attempted to convince the patient to go to the hospital. What was the plan? Stay home and monitor. The AMA patient explanation, this was another way for that provider to capture exactly what he explained to the patient, like you just read in the narrative. The patient informed that a 12-lead EKG can only capture an active STEMI, a heart attack, but the most definitive way to rule out a heart attack is the lab work at the hospital. The patient is also informed that because her blood pressure is high, there's a risk of stroke, and she should contact her PCP ASAP to be placed on an antihypertensive medication. Again, excellent narrative, excellent way to fill out the AMA section. The provider went down and he, in his narrative as well as this section, knocked out all the indicators for the sign-off to include the patient age was over 18 years of age and that more than just BLS care was rendered. Again, those two boxes don't necessarily cause any sort of confusion when it pertains to the sign-off itself. It's a data collection point, and it's also important to have for thoroughness. As it pertains to the signatures, the EMS provider signed it, as well as the patient, and the patient refused care, refused transport, but allowed for the HIP in the release form. So, for the patient itself, it's always important to make sure when they sign off that you get the refusal of care, refusal of transport, the HIPAA acknowledgement, and release for billing in the reasons. Always date and timestamp when they signed it, type in their first and last name, and make sure they get a signature. A point of emphasis that I like to teach regarding your PCR and your documentation is best practice involves having your partner who is on that call with you proofread your PCR before you post it. This is a legal document, so it is excellent to have two sets of eyes to read it before it goes into their medical record. In conclusion, remember, our documentation is always important, regardless if it's a sign-off or a transport, but there's an increase in legality and an opportunity to go to court on patients to which you sign off versus any other type of call. Make sure you have good, thorough documentation so it can represent you well if you go to the witness stand. I hope you learned something today. If you have any questions or comments, please feel free to email me at my first and last name, bradchiquin@yahoo.com. Thanks, everyone.